Hi, my name is Shelly Martin, and welcome to today's video on heart blocks. Today's video is intended for experienced telemetry nurses who've already had a basic EKG course. If you haven't done so already, please download the case study attached to the discussion board. We'll be going over the case study after the presentation. So the learning objectives for today are to apply a stepwise approach to heart block interpretation, to correctly interpret heart blocks present on an electrocardiogram, and to implement appropriate nursing interventions for patients experiencing heart block. So step one would be to calculate the heart rate, and you can do this in 3 different ways. First, you can count the number of R waves and multiply by 10, or you can count the number of large boxes between the R waves and divide by 300, or count the number of small blocks between the R waves and divide by 1500. Next, you would want to determine the regularity of the rhythm by measuring the distance between the R waves, and determine if the P waves are normal, are they uniform in shape and size, and is there a QRS complex after every P wave. Then you would measure the PR interval. Is it normal? Is it between 12 and 20, or 0.12 and 0.20? Or does the PR interval vary? Then you want to look at the QR measurement and see if it's less than 12, and put all of those things together to come up with the interpretation. So the first heart block we're going to discuss is first degree AV block, and normally in this rhythm, you're going to have a normal heart rate, usually between 60 and 80. It should be regular. So the distance between the R waves would be the same. All the P waves would be normal and upright, and the distinguishing characteristic of this heart block is that the PR interval is 0.20. The QRS measurement is normal, and this is usually a benign rhythm. You would just want to monitor the patient for any adverse symptoms, notify the provider if it's a new rhythm, and look for any underlying cause like medications. And the second block we're going to talk about is second degree AV block Mobitz 1, also known as Winky block. And in this rhythm, the heart rate is going to be, normally the atrial rate will be normal, but the ventricle rate will be decreased. So it's going to be an irregular rhythm, as you can see here. The P waves are going to be uniform and upright, and the PR interval will be progressively longer, followed by a drop beat, and this is the distinguishing characteristic of this rhythm. And the process repeats itself. The QRS measurement is normal, and this is usually well tolerated by patients. Of course, you want to notify the provider if it is a new rhythm, and anticipate an order for oxygen, atropine, or external pacing if the patient's condition deteriorates, and look for an underlying cause. In second degree AV block Mobitz 2, you'll also have a normal atrial rate with a decreased ventricle rate, an irregular R to R. The P waves will be normal and upright and uniform. And the distinguishing characteristic for this rhythm is that the PR interval is constant, with some QRS complexes being absent. The PR interval may be normal or prolonged, and the QRS complex could be normal or wide, depending on the pacemaker of the ventricular rate. You would monitor for tolerance. There is an increased chance of this rhythm leading to third degree heart block. It's a more serious rhythm. So you would want to monitor the vital signs frequently, notify the provider, anticipate oxygen, external pacing, and look for underlying cause, but you would not want to use atropine necessarily in this rhythm, because it can actually lead to an increased atrial rate but a decreased ventricular rate, leading to more decompensation in your patient. third degree AV block, there's a discommunication between the atrial and the ventricles. So you're gonna see different atrial and ventricle rates as each has its own pacemaker. And the rate is usually gonna be between 40 and 60. It is regular. The P waves are usually upright and uniform, but there's gonna be more P waves than QRS complexes. The PR interval is not measurable. The QRS measurement could be normal or wide, again, depending on the pacemaker. And the nursing implications for this rhythm is that it's not well tolerated by patients. Your patients will usually be decompensating. So you would notify the provider. You're going to anticipate oxygen, atropine, external pacemaker, and possibly getting your patient ready for surgery, for a permanent pacemaker. So let's go over the case study. You're caring for Mr. Heartbreak, who's a 72-year-old male with a history of an inferior MI. He's been admitted with digitalis toxicity. Let's use the 6-step method to interpret his rhythm strip. So, looking at the different R waves, we see the rate is 50. The rhythm is irregular. See over here. The P waves are all uniform and upright, but the PR interval gets progressively longer, as you can see. The QRS measurement is about 0.6, or 0.06 rather, and so we have a second degree AV block, Mobitz 1, or Wiki block, because of the progressively longer rhythms. So Mr. Heartbreak's vital signs are blood pressure 140/90, heart rate 56, respiratory rate 18, and temperature is 37 degrees Celsius. He says he's not dizzy and doesn't have any syncope. So what would we do for him? Well, again, we would just continue to monitor him. So our next patient is Mrs. Erratic. She's 82 years old and has a history of ischemic heart disease. While caring for Mrs. Erratic, you observe that she's short of breath and hypotensive. Let's interpret her strip. Well, there's a ventricle rate of about 50, and the atrial rate is about 90, if you count the P waves. The rhythm does look regular. The P waves are uniform and upright, but there's more P waves than QRS. And the PR interval is not measurable. The QRS measurement is 0.08. So we recognize this as third degree heart block because there is no communication between the atrium and ventricles. So our priorities for Mrs. Erratic are going to be to notify the physician, to continue to monitor her vital signs frequently. We're going to anticipate atropine and transcutaneous pacing, and possibly a dopamine infusion. So our next patient is Mr. Achy Breaky. He's a 55-year-old male with a history of coronary artery disease. He's been admitted for an acute anterior MI. Let's look at his strip. Let's see, his rate is 50. His rhythm is irregular. His P waves look uniform and upright, but some P waves are not followed by QRS complexes. The PR interval is 0.10. The QRS measurement is 0.06. We recognize this as second degree AV block because each PR interval is the same, but there's some drop complexes. So our nursing priorities for Mr. Achy Breaky is to continue to monitor his vital signs frequently. As this can progress to third degree heart block, we're going to monitor his rhythm strips frequently as well. We're going to have transcutaneous pacing available at the bedside, anticipate an order for oxygen, and possibly a dopamine infusion. Okay, our last case, we have a 65-year-old female on the telemetry unit who has a history of rheumatic heart disease. Her vital signs are stable, and she denies dizziness or syncope. And this is her strip. Her heart rate is 40. Rhythm's regular. QAs are uniform and upright. The PR interval, though, is 0.34. So right away, we can really see that this is first-degree AA block. This concludes the presentation. Thank you for joining me.